And this should be accompanied by improvements in continuum of care, sexual reproductive health, family planning, and newborn and child survival. Because we all know that maternal death and morbidities will really impact on the baby survival and even growth and development. So when we did not achieve the MDGs, there was a renewed focus through SDGs on ending preventable maternal deaths. And the global target which we were given was that every country by the year 2030, they should reduce the maternal mortality to less than 70%, and no country should be still above 140 deaths per 100,000 normal deliveries. So this has been further positioned globally by the Global Strategy for Women's, Children's and Adolescent Health, which dates back from 2016 to 2030. So apart from that, the ICPD 2025 meeting conference, which was held in Kenya, also came up with commitments where in our division we are targeted to deal with the 3 zeros, that is 0 preventable maternal deaths and morbidities, 0 unmet need for family planning, and 0 unmet need to gender-based violence and harmful practices. So globally, we know that around 295 women die yearly and 2.4 million stillbirths happen each year. Then in Kenya, we have about 6,000 maternal deaths within a year and 35,000 stillbirths which occur every year. So our status now, according to the census of 2019, we are nationally at 355 maternal deaths per 100,000 live births, which has, if there is no statistical significance between where we were at 2014, that was 362. So we need to think around that. And with this, around 22 counties are still above the national MMR, which is 355. We have Garissa at 641, and we have Nyeri at 67. So Nyeri, they have somehow achieved the MDGs, and we hope they will maintain the momentum. So when we go to the facilities, we get the data from Kenya Health Information System at the headquarters. We find that the facilities which reported deaths, 2019-2020, it was 100.6 per 100,000 labours. 2020-2021, 110. 2021-2022, around 112, meaning that there is an increase. And this increase does not mean that women are dying more than they were dying before. It's because people are already aware now, and they are able to audit the maternal and perinatal deaths and upload into the KDHIS, because we've seen that there has been an increase in people reporting the maternal perinatal deaths. From 2018, it was at 89.6, and by 2021, the reporting rate had increased to 96.1%. So our other indicators, ANC, the fourth, is still at 53%, which needs some attention. Skilled birth attendance, we have tried around 80%, that is according to KHIS. And the total fertility rate, you saw from the KNBS census, we were at 3.4, which is still not departing so much from what we had in 2014. That was 3.9. Modern contraceptive prevalence rate among all women is still at 58. And unmet need for family planning for all women, not married women, is at 14%. So we can see that skilled birth attendance has increased. Why? Because we have less financial barriers now because of the Linda Mama and even UHC. Then there has been an efficient road network across most of the counties apart from a few. Women are also informed, and we have good ambulance coverage within most of the counties, as I had yesterday. But maternal mortality is still high. Why is it still high? We have increased access, but we have also increased mortalities. And this is attributed to poor quality of care, which was alluded to by many of you who have presented different researches. So we have seen that Kenya has put improving of quality of healthcare services as a priority. And this one is entailed in our policies, the Vision 2030, and even the overarching policy, which we have Kenya Health Policy 2014 to 2030. So what could be the reasons for this? It's because of poor quality care and an enabling environment where we have shortage of skilled personnel, poor deployment of trained staff who have been trained in IMO in the right place, inadequate skills in management of obstetric emergencies, and this one was seen very well in the CMD of 2017. Also, we have inadequate supplies of equipment, essential medicines, and commodities, and poor leadership and governance. Because where there is poor leadership and governance, all this I've talked about will happen. Then we've also seen that there is high staff turnover. They are going to greener pastures. Some of the staff never adhere to referral protocols. And all the three delays will cause poor deaths to these mothers. So we really need to work using the set standards. Then also the
Good morning, colleagues. Good morning or afternoon. Afternoon, colleagues. My name is Bridget Wesamba. So I'm going to make a presentation from the Division of Neonatal and Child Health. From yesterday, we've been talking about the mother. Where is the baby? Where have we left the baby? That's the question I'm asking midwives in this house. Okay. So globally, child survival remains an urgent concern. The first 28 days of life are the most vulnerable time for child survival. And we do not want them only to survive, we want them to thrive and do what? Transform. So children face the highest risk of dying in their first month of life, that is during this neonatal period, at a global rate of 18 deaths per 1,000 life births. Kenya, we are at 22 per 1,000 life births. And by the year 2030, if we are to meet our SDG goals, we need to be at less than 12 per 1,000. So if we are not going to embrace the interventions, we might reach that goal by the year 2050. So about a third of all neonatal deaths tend to occur during the first 24 hours of life, and close to 3/4 in the first. And this is where we lose most of our newborns. Now, what are the leading causes of death in newborns? As you all know, we have intrapartum-related birth events like birth asphyxia, we have prematurity, and then we have what? Sepsis. Now, let's look at that pie chart. It's not an interesting one, because currently we are losing the under 5s, and neonatal death accounts for 45% of all under 5s death. And that is not actually pleasing. It's not encouraging. We need to do more. So as we can see from that pie chart again, reasons for admission in our NBU, see, because of birth asphyxias, sepsis, and prematurity. And it's the same reasons that these babies are dying. So what are the national policies, guidelines, and interventions we've put in place? We have the newborn care protocol. I think most of us must have seen that book. It's for use in level 4s and above. And we did a validation. So it's just waiting to go for signature, and then we'll be able to disseminate. We have the primary healthcare guidelines for health centers and dispensaries. Also, printing. We are waiting for our partner to print, and then we disseminate these protocols, these guidelines. And then KMC implementation and training manuals. KMC for our preterm babies. What do we see when you go around facilities? Do you have a KMC room? Yes. Can you have a look at it? Kuingia ndani, what is there? We've converted them into stores. Keeping incubators and all that. Why don't you have KMC babies in the KMC room? We've never had babies who need KMC. When you look, we go through the MOH 333, that is our delivery book. We see, for example, in this particular month, you had like 30 preterm babies. Walienda wapi, we refer them. Walienda wapi, walienda nyumbani. So, bona tu kuanzisha watoto kwa KMC. So as we all know, data never lies. And then now we have the clohexidine for umbilical cord care. Again, I would ask midwives in the house, how many of us believe in clohexidine? How many of us advocate for clohexidine for our newborns? The majority of us, if I'm not wrong, we do not. Clohexidine is best applied when we cut, immediately you cut the cord, apply clohexidine. What do? We give our women to go with CHX to the ward. We don't even know how to apply that CHX as midwives. Okay, so vitamin K, it's not in the slide, vitamin K, where is it administered? It's supposed to be administered in labor ward. What happens? It's only administered to babies who are admitted in newborn units. What happens to the rest? Mungu saidia. And we are seeing this in facilities, and there is one county that is reporting high cases of hemorrhagic disease of newborn because a nearby facility does not do what? Administer vitamin K. Now, essential newborn care training package for frontline health workers. This is ongoing. So far, we've trained 8 counties, and the counties we've trained, we've seen a reduction in neonatal deaths. We've targeted priority counties where neonatal deaths were actually high. Now, other policies, then integrated newborn supportive supervision. We did this in 6 counties. So we are yet to do in 42 counties. Newborn care assessment amid COVID-19 infection is an assessment we carried out as a division. And we were just to check the services being offered where newborns are cared from, right from labor ward. So during the pandemic. And then we have TWGs, we have assessment of KEAMC implementation across the county. And currently, we are setting up maternal newborn child learning hubs. Kakamega is one of the pilot counties, Nairobi, Garissa, Kilifi, and Turkana. So it is a learning hub. LSTM, we are still partnering with you. So this learning hub, we need our young ones, even us, to go and refresh our skills. It's not a skills lab, it's a learning hub. So success, we've introduced inpatient neonatal register, and our key indicators are there. We have also reviewed CHX guidelines. Remember, women were applying CHX wapi? Kwa macho ya watoto, sindio? What was happening? Blindness, huh? Even as recent as the month of July. I will not mention that facility because it's here. So, yeah, so we've also included possible serious bacterial infection into our INCI for management of sick young infants in situations where referral is not feasible. Okay, challenges. We have not all counties are rich in newborn care interventions, and then newborn care supervision is limited to specific counties. We need to scale up to the whole country. So thermal care, those are priority interventions. For newborn care, you will give me 1 minute just to demonstrate something for 1 minute. Promote capacity building to our healthcare workers, providers on early essential newborn care, early insertion of breastfeeding, CHX. I think I've mentioned all these. We have CPAP for care of preterms with RDS, respiratory distress syndrome. And then we are also advocating for use of the inpatient neonatal register to improve data collection. So thank you so much. I still have 3 minutes, Chair, that I want, or 2 minutes. And as we talk about MPDSR, my colleague Clarice from our sister division, we are working together to strengthen the P. Tangu jana nasikia tu maternal. Mtoto tumemwacha wapi? Na wauliza. In P, because 70% of facilities in this, of counties, we have 47 counties, they do not audit perinatal deaths. Yesterday we talked about EMOC. I'm talking with a lot of concern for the newborn. EMOC, a lot of emphasis. Inaekwa wapi? Where is our newborn in EMOC? Where is the N in newborn, my colleagues? MPDSR. We are also coming up with tools to strengthen also neonatal death audits. Thank you so much. That is, but I kindly ask for 1 minute because I have 1.5 minutes. I just want to demonstrate something very simple. Thank you.
Okay. Welcome here. So our babies are born. Hypothermia is undocumented and recognized. Our babies are dying because of hypothermia. It begins in labor ward. As midwives, madusha tumefungua wazi. Simefungua wazi kwa nini? We want fresh air. We don't care about the baby. In theater, tuko na nini? AC ni ya nani? Ya daktari. Because utaka sikia nini? What about the baby? Okay, how do we dry babies? We're taking the loose because of evaporation. Tunaacha the metallic forceps on the baby. As small as it is causing a lot of hypothermia. Sijui kama wakati wa baridi kuna kitu cha kukuza baridi. How do you feel? Check off. Now, again, the babies were open. What we call it, they also lose. You all know those methods. Let me concentrate on this one. Allow me to do this demonstration. So now, in school you were just told, mtoto akizaliwa, you do what? Dry the baby. Well, we taught that skill of drying the baby. Please, as we're talking about quality, talking about from evidence to practice to reality. So, this is my baby. Gladys. Okay. Mama. And we are running away. I think my sister department, Clarice, from supine positions, but anyway. So the baby is coming out. Remember, there's this drip. On the mother's abdomen. So as I deliver this baby, I put the baby here. I have 30 seconds, whether the baby is breathing or not. I have 30 seconds to thoroughly dry this baby. So how do we dry? I have this cold towel to myself. The baby is on the mother's abdomen. So I'll pick like that. I'll start from there. Huh? Okay, I start from the eyes, the nose, the mouth. And I'm not farting. I'm doing what? Drying, thoroughly drying as I stimulate. And I'm not doing that also to injure the internal organs. So look at this. Eyes, nose, mouth, face, neck. I have 30 seconds. Neck. Come like that. I'm not farting. I'm not giving love parts here. Arms. I come like that. Miku. Like that. I hold my baby. I support the head and the neck. I turn my baby still on the mother's abdomen. Head. You know, like that. Come like that. I'm stimulating. As I dry, I'm stimulating. Baby already is crying. Initially, my baby was not crying. My baby was not breathing. I'm not worried. Thoroughly, please. Dry the baby. Do not panic. So I do that. Remove this first towel. And then I'll cover. I'm not wrapping kwa mama because we are promoting skin to skin. Weka mtoto hapo, valisha kofia. The head loses 65% of the heat. Subject this newborn to what? Hypothermia. After that, leave the baby here. Do not force the baby on the breast. Ataanza kunyonya. Unamforce kama nini? What do you need to do? Then develop breastfeeding cues. Bridget could take 5 minutes because I've maneuvered through the bony pelvis. Another will take 30 minutes. 30 minutes, yes. Let the baby be here. They start drooling. They start leaking. Matiti wenye? Thank you so much.
Hello. I think the first presenter never bought those nice gloves. That was powerful.
Well, I think that's a good presentation, and though we've given you some extension of time, but as we normally say, if you forget everything about the the conference, including my face, then please just remember how to dry the work the people. But I can tell you by then myself, actually, I was not doing that scientific the way she has done it. So I've learned something in this conference. And so, well done to the presenters. The next presenter is Eddie Dulo from KMET. Where is he? Eddie Dulo? Oh, Bidi. Eddie Bidi, okay. Yes? Eddie Bidi. Oh, Lindy. Oh, is he? Okay, is he Eddie Dulo? Sorry? So, okay, didn't deserve her. She's a Kenyan Jesus Community Health Nurse. She's a BSN in Public Health. Also holds the Masters in Public Health with a bias in health promotion. Worked at Kakamega County Referral Hospital. Currently, she's working with KMET as an innovator, program coordinator, and current project manager of uncontrolled PPH using a bundles approach. So welcome on stage, Eddie, for your presentation.
Good afternoon, everyone.
Good afternoon.
I would like to say I'm Lady Dulo. Very specific. I'm not going to give a scientific presentation, but as a partner, I just want to remind us of a few things that we do at KMET. First of all, receive greetings from KMET. Most of the midwives have worked with us in several locations, within your facilities, within your departments, and we've met in several forums. And so, giving a speech or giving a short presentation about a mother after a vibrant talk about the baby is not very easy. But because they go together, the baby department will just allow us to emphasize on the mother because it's the mother who brings the baby. But then, we still should not forget about our babies. We are known for maternal health innovations at KMET. And we narrowed down this program to postpartum hemorrhage, uncontrolled PPH. We have been training health providers and supplying an equipment or a kit known as the uterine balloon tamponade. Most of you have been in touch with me with the balloon tamponade. But this has not improved the maternal. WHO and other partners have come up with something known as the bundle approach. In our class 1 and 2, we were taught about a bundle of sticks. So in medicine today and in midwifery, we are looking at a bundle of interventions put together to manage a mother who is bleeding excessively. And that's why we title it Uncontrolled Bleeding. You have done all that you can, following the protocol, but still the mother is bleeding. So in a nutshell, what is a bundle approach? I know some of you have heard about it. We have trained quite a number of facilities and counties on this. I'll just give a small emphasis on it. So what is unique about a bundle approach? In the bundle approach, we are looking at the clinical approach and the non-clinical approach. It has been noticed that most health providers are not good in the non-clinical approach. When we talk about the non-clinical approach, we are talking about communication, teamwork and communication, network integration, leadership. All this combined with the clinical, where we use the oxytocin and the protocol of managing PPH, we are going to save these women. Most of you can attest to it that teamwork and communication is lacking within us. And these are things that have been identified as contributing factors towards delays when we are managing postpartum hemorrhage. So we are emphasizing that once we use the protocol of management of PPH, we must have our facilities ready. Having your facility ready is an unclinical component. Your facility must be ready. How should it be ready? We must have an obstetric team that is going to manage PPH when PPH occurs. So we are encouraging all facilities that conduct deliveries during our trainings to make sure that they have a team, an emergency team, that when the midwife in labor ward calls for help, then that team comes in to help. A lot of delays are within our facilities. I want to give a small example. You draw blood and take it to the lab. You're from maternity labor ward. Our lab colleagues will ask you, is that the only patient that you're telling me to harakisha damu, si ndio? Because they don't understand the magnitude of that one, losing that one woman. What is the price of a woman? What is my price as a woman? So when we are doing a PPH bundle, we do a facility orientation. We basically orient every single person working in this hospital to know that when a mother has PPH, then all of us are involved and all of us must come in to help. So a few additional things that my other colleagues have mentioned in this bundle, we have tranexamic acid, we have the carbetocin, we still have the balloon tamponade, and then we also have the anti-shock garment. So all this put together makes the bundle. And remember, we are emphasizing on the non-clinical. We must know our network of referral, our network of management. Within your facility, do you know who is around you? Who can help you when the ambulance is broken? Because those are the places where we get the delays. Within the facility, who can come in to help when we have PPH? We are also emphasizing on data collection. How would we know that the country is doing well in maternal mortality rates if we don't collect data? So the bundle approach looks at it widely, and it's not a one-side show. It's a multidisciplinary action. Our leadership in our facilities. We want UBT kits, they are bought. We need anti-shock garment, they are bought. I'm in maternity, I'm in labor ward. I don't have an anti-shock garment. Who is supposed to help me get it? Who is supposed to procure this for me? So in managing PPH, let us look at it as a wide approach. The leadership is involved. The health worker is involved. The community is involved. And one scholar said that women are still dying because we have not decided that they are not supposed to die. And I think, I believe in that because delivery is not a disease. Delivery is a noble thing that women are doing, bringing another life. But then when negligence comes in, women die. I have 3 minutes, I'm just finishing. When a woman dies, it's really heartbreaking, from the watchman at the gate to the nurse in labor ward. And I know that is why most of us look at PPH, killing women, other complications like eclampsia. We have also obstructed labor. And so that's why we're talking about the women more and more. My parting shot is that let us embrace the bundle approach that has been brought to us. As KMET, we are rolling out with the Division of Reproductive Health. I think soon we are having a training for about 3 counties together. And we are coming in as partners. Luala PSK, my colleague is there. Luala Community Alliance, I don't know if they're around. We have come together to support the rollout that the DRH is doing. They are rolling out the revised mentorship program. And all that we are talking about is already in the mentorship. We don't want to be a standalone program. So we have supported the mentorship manual, publication and the process. And so we are working with them so that all the 47 counties, our mentors are going to be trained on how to use a bundle approach and other measures like resuscitation of the baby so that we manage our mothers and our babies well. Otherwise, I want to thank you all for being good midwives, and I hope to meet you at the facility so that we manage our women well. Thank you. Thank you very much. Thank you.
Hello. Oh yeah, hello, let's give a better hand clap, please. So, hello. Thank you very much for the presenters who have been there. We are now waiting for the keynote address. So anytime, ni hawa tu ndio watatuonyesha the way forward, lakini tutasikia mziki kidogo.
Very nice. Very nice. Very nice.
You can dance in situ. Mnataka demo. Demo. Wapi demo? As we wait for the... Hello, as we wait, I think the three who are presented, can you come up and then we have a small plenary? So as soon as the online program starts, tutakatisha, si ndio? And let it not be unjustified episiotomy, si ndio? We will just allow the normal labor to continue. Sawa sawa. Microphones itembee, please. Questions? Questions?
Okay, good afternoon. Good afternoon. I want to appreciate Lile, Clarice, and Bridget for that good presentation. I have two questions or comments. One goes to Bridget. She mentioned that there is, I'm Jiro from Embu. She mentioned about the child who went blind. I just want to understand, after cloexidine, after CHX, the child went blind. I'm sure it's from an account here or not here. I want to know maybe what did the ministry, where our supervisors do about the product, because the ointment here, macho, tetracycline, and the cloexidine, they are the same. Despite educating the mothers, we don't supervise at home. Maybe CHVs do, but we need to know what was done. The second one is about KMET. I appreciate you. I know we are having a problem in completing the KMET. What does it mean? And you have mentioned the facilities. I don't know whether there is any facility you are piloting in Embu County. Thank you.
Thank you very much for those questions from Embu. I thought there was one thing we made upright. We are not mentioning any county here with anything. Sawa?
Thank you so much. Mine is about how to dry the baby. It is just something additional to what the presenter has said. I don't know whether it is used here, but usually we are guided by the color of the lycra. Is the color clear or meconium stained? That one guides the drying. If now the meconium, the color is meconium stained, you may, usually they clean the mouth first because of aspiration. Thank you. This is just an addition.
Natoka Uganda. Sindio? Any question?
Yeah, we have a question here.
Microphone zingine zitembe.
Okay, we have a question. And it's directed to the one who presented on maternal mortality indicators, MNH. Yes. Thank you so much for the presentation. And it is good that we are seeing our indicators improving. In fact, I was looking at family planning and mate need. I knew it was 18, and this time it is around 13, which is 14, which is very good. But now, we are talking of maternal mortalities. And maternal death-related maternal mortalities that we have, if we look at them, they come from PPH, sepsis, eclampsia, all these things. And if you look at all these, they are preventable. If only we can maybe upgrade our facilities, right from level 2, level 3, level 4, referral system, and all these, we can really lower these. So what I was asking, what is the national government doing so as to improve the quality of care of these mothers? Because we have seen many mothers losing their lives, not because the midwife is incompetent, but because she's working in a resource-constrained area. She knows what she's supposed to do, but she doesn't have that equipment, she doesn't have that supply, she doesn't have that drug that she's supposed to use. What is the national government doing so that we can be able to offer the quality care to our mothers to reduce the mortalities?
I think we shall stop there, and Boniface is going to add on. We answer these questions first before we continue.
Yes, I want to add to what my colleague has said, and I want to direct this question to. I want to direct my question to the last presenter, who has talked about PPH. Most of us work in facilities where every day we manage mothers with these obstetric complications. And from the experience, what I've realized is that we don't develop modalities on how to manage PPH and these obstetric emergencies. 80% of PPH can be controlled. Maternal mortality associated with PPH can be controlled. What is the problem? You find a hospital is called County Referral Hospital, and it's referring a mother who has PPH 100 kilometers to another hospital. Let's have deliberations on how to prevent this. My recommendation is, in your labor ward, in your maternity centers, can you form teams which will develop protocols on how to manage PPH? Because 80% of PPH can be controlled, and what I've realized is that midwives don't examine mothers. Postnatal mothers, once the mother has delivered, postnatal won't very fast, we don't examine, we are just sitting. Please, let's do examination of mothers post-delivery, and before you refer any mother who has delivered, let us have protocols. Start transfusion of that mother. Even you can refer that mother, you know, with on transfusion and also escorted by a nurse. We have seen so many scenarios we can't mention. So my colleague midwives, let's bring change. We have come here to learn. We have come here to create change in our maternal mortality and the health of mother and baby. Let's go back and form teams in labor ward in those areas and ensure that we don't rush calling, we are what miracle is this hospital going to do for management of a mother, and you have a theater and you have a consultant? Let's be empowered and let's do the right thing. Thank you.
Yeah, thank you so much. Allow me to stand. I'm vertically challenged. Those sitting at the back may not be able to see me. Now, I stand up wapi. Okay. No, I can't be seen. You are now bullying me. That is harassment. Now, yes. We're applying a CHX solution in the eyes of the babies. Babies were getting blind. Cases were reported. What did we do as a division? We had to go back to the drawing board. And we said, can we bring stakeholders, all stakeholders on board and ask them, what is the problem? Right from the Pharmacy and Poisons Board, county pharmacists, all divisions, everyone was brought on board. And then we had to deliberate on that. So we also my colleagues went to the communities, asking with CHVs, asking women, what can we do better? So we as midwives, where do these women get CHX? Is it from us? Is it over the counter? And if it's from us, how do we package our messages to these women? Are we informed? Are we knowledgeable on how we need to apply this? Those were the questions. So, what we did, currently, CHX is only being produced in gel formulation, not in solution anymore. And how do we package our messages to these women? Tunawapatia box, tunaambia mama enda. Mama anaenda post. The other day I was working in newborn. The woman comes day 3 with CHX. Sister, nimeambiwa nikuje na hii. Na sijui nitaweka wapi. Shida iko wapi? Alipewa labor ward, ndio? Nakuambiwa. So, if we don't package the message and tell them how they are supposed to apply, ataona hii ni kama ya macho. Wacha niweke kwa So where is the gap? So ni sisi healthcare providers. So that's what we did, and now KEMSA has CHX. You know, once a product comes, because we began on a wrong foot, and that we shall admit, when Esther took me to be in charge of newborn, it was just dumped. We dumped things by one of our senior partners. I'll not mention the name. Unakuja unapata a product in the unit. You have no idea. So what we are saying, let these products come and let us properly disseminate the information on how products are supposed to use, on how registers are supposed to use, on all commodities. Nasikia saizi naitwa HTP, Health Products and Technologies. To my colleague in Uganda, first and foremost, thank you so much for your yesterday's presentation on birthing positions. That was, I really enjoyed that, and something we need to impress. Current guidelines, a baby is born through meconium or not, we still dry and stimulate the baby. The other were what? They have been outdated. Where we used to ask, is there meconium or no meconium? No meconium. Okay, do not dry. But the current updates, WHO updates, which we have adopted as a country, whether a baby is born through meconium or not, you do what? Dry and systematically. systematically and thoroughly dry that baby as you stimulate. Si kufanya fanya hivi, that's not drying. Dry that baby to stimulate. Thank you so much. I hope I've answered those questions.
Good afternoon. Good afternoon. Yeah. So thank you, my colleague who has asked about what the government is doing, what the national government is doing to make sure that we've ended this preventable maternal death. And as my colleague has put it right, it is us now to redesign how we want to work. Nevertheless, when I started, I talked about devolution of health services, where the national government was left with around 4 issues. And when I was presenting about the interventions, so we stop. Okay. Yeah. Okay. So I want to be very brief because I'm told the person who is doing the keynote address is on the stage. So the only commodities which the national government is now supplying are the FP commodities. But for the rest, like the equipment, these are the drugs, it is the county government. And what we've seen when we've gone around, most of the counties, they are not able to get drugs from KEMSA because either they have a very huge bill with KEMSA. But largely we work with partners, and I think that is why we are not at par, all of us, at all the counties. Yeah, because the trainings I'm talking about, we do it right from level 2. Right from level 2, which is dispensary, they get all those trainings. So we only need to lobby. In fact, I was saying now that we have the new government and new governors, please try and see how you can reposition health services, especially for the maternal newborn health. Yeah. Otherwise, we've done the best. We've done the policies, guidelines, standards. We have MNH, QOC standards, which is very good. If the facilities use it to assess the services, and you have equipment and enough staff, we can be able to do this. And another thing I wanted to add, I wanted to urge the researchers now that let's look for, I've mentioned a few reasons why we have poor quality of services, why mothers are dying. But can we go deeper and look at what is it? Yeah, because he has put it very right. We have the skills. So what is the problem? Yeah. What is the problem? So until we come up with a research, something, because we don't work on hearsay, something which you can take to the policy makers and see, we have talked about maternal deaths over and over, and we are not going anywhere. So this is the problem. Can we have an intervention here? Is it equipment, skills, whatever it is? Yeah. So we've done the best, but now because of the system, some things we cannot manage to take care of. Thank you so much.
You can clap, Cindy. Ataskia. Let's clap for them. Since she's appearing on the screen, I think we are almost there.
The airline had lost my bags. That
make I just
afternoon. How are you? Our keynote address.
Hello?
Hi, Muna.
Hi.
How are you? Thanks so much. It's good to have you.
Thank you so much for having me.
Yeah, Muna Abdullah is UNFPA representative for Africa. They have worked together with maternal neonatal stakeholders in Africa, and more so there's a close focus in narrowing down the focus to East Africa, Central Africa, and South Africa, knowing that we have the same concerns in terms of maternal mortalities and neonatal mortalities. So the countries have united together so that they can create a common understanding and way forward to ensure that those common agendas are addressed based on ensuring and ending preventable maternal and neonatal deaths. So welcome so much. Karibu, that's how we say it here. So thanks. Muna comes from Ethiopia, and welcome, and it's good to have you.
Thank you so much. Really appreciate. I hope you can hear me. Okay. Thank you so much. It's really a privilege to join you in your ACE scientific conference. It's always been a pleasure working with Midwives Association of Kenya. As it has been said, I work for East and Southern Africa countries regional office where Kenya is part of it, and strengthening midwifery program is our main program, and we have been working with Mark for quite some time now. Really happy to join you. I hope you have a great start yesterday and this morning. I have a small presentation to share from my side, if that's okay. Okay.
Yes, go ahead, Muna.
Can you see my screen?
Yeah, it's loading.
I'll put it. Yeah. Okay. So just to look at from evidence to reality, from the regional office, we do surveys, we do assessments to look at the state of midwifery in 23 countries in our region, including Kenya. And recently from headquarters also evidences have been coming out. Before, if you remember, a few years ago, there were very little evidence on midwives, but nowadays a lot of evidences are coming out, and we have now know that midwives can play a broader role. It's not limited to maternal and newborn health only. We are talking about advancing primary health care, universal health coverage, and midwives can be a change agent in the community as well, including prevention of female genital mutilation, advancement of family planning, women empowerment, and other new approaches. For example, self-care approaches nowadays are more popularized in our region recently, and midwives can play a role in that self-care. Midwives can save lives also. This is a study which is published in Lancet, and they have a scenario, 3 scenarios, and one of the scenario, if we have universal coverage of midwives, which means if every birth is handled by a skilled birth attendant, they predicted that it's possible to save 1.2 million lives in East and Southern Africa region alone by 2035. And midwives can help also avoid over-medicalization. As you know, cesarean section, high cesarean section, unnecessary cesarean section is becoming more and more a problem when there is increased access to services. So midwives also, there is a study which shows that midwife can help avoid over-medicalization. And then that is the universal coverage, the 100% coverage of midwife. But even a modest increase, like 10% increase in coverage every 5 years of midwives, the evidence shows that 22% of maternal deaths can be averted, and 23% of newborn deaths can be averted, and 14% of stillbirths can be avoided. And I will not go through it. It's a different scenario, but it shows really evidence. And at the regional office and globally, as you can see, this State of Midwifery report, it's been produced since 2011. But it was not done periodically. The second one was 2014, and the third one was 2021. But at the regional level, we did in between in 2017 and 2022. So in our region, in East and Southern Africa, this is the composition of the health workers that can provide sexual reproductive, maternal, newborn, and adolescent health. And midwives constitute a very small portion. You see the unavailability of midwives in the region. We have only 146,000 midwives in the whole 23 countries, and most of them are accumulated in a few countries. And there is a huge variation according to the income of the countries. High and upper middle income countries, of course, have more midwives than the others. But at the regional level, we have about 2.5 midwives per 10,000 population. And then this slide shows also where the most shortage. We say that there is 300,000 midwives in short now. We need these 300,000 midwives to meet the need, but some countries really have the worst shortage, and these are Burundi, DRC, Eritrea, Madagascar, Malawi, Mozambique, Tanzania, and Zambia. And we identify also the quality of education, quality of midwifery education, and I'm sure you have yesterday maybe you have shared this the Kenyan data on quality of education, but in our country only 5 countries offer direct entry to midwifery, 5 offer post-nursing only, and there is also a mix. The most important part is the direct entry or the post-nursing. It should comply with the ICME standard of at least 3 years for direct entry and 18 months at least for post-nursing. The other thing is most countries use midwives to teach midwives, but some countries, they don't really use midwives to teach midwives. Other health workers are teaching midwives, and we encourage midwives to teach midwives. This is based on a recommendation from ICM and promoting the midwifery profession. The other is postgraduate. Many countries, from evidence in the beginning, there were very few countries who does even masters in midwifery. Only diploma and BSc, that was the limit for midwifery. But as we go along in the past 5 years, more and more countries start giving masters and even PhDs. So from the 23 countries at the moment, 10 offer either masters or PhD in our region, which is a good progress. And this is, it's the ICM definition of midwife. I will not go through it. And this is a standard of midwifery education. And we looked at all the 23 countries, and it shows whether legislation recognized midwife as distinct from nursing or distinct regulatory process, if they have distinct regulatory process, or a standard curriculum is used by all schools. Sometimes you find different curriculums applied in different midwifery schools, but is there a standard curriculum? And if that curriculum is aligned to the ICM essential competencies. We also looked at legislation and regulation, and this is the weakest part in the region for most countries. And this is what we also would like to engage more and more in terms of strengthening the capacity of legislation and regulation, and the most important part is, you know, the regulatory body and the midwifery association. Usually we don't work closely, and in most countries it is the nursing council that also regulates midwifery workforce, and in some cases it's a body in the Ministry of Health who regulates all health workers, and it's not focused on midwifery. So due to these things, we have a really the weakest part from our education, practice, and regulation. It's the regulation and the legislation which we find struggling in most countries. And you will find some countries, they don't even have licensing. After training, they go directly into practice. So we have to really share lesson among each other to build capacity. Some may have licensing, but once you get the license, you can practice. There's no real licensing, and that also puts the woman with a safety issue unless you have real licensing and continuous evidence of continuous professional development. There is a country profile also. Kenya also have this kind of country profile, which we would like to encourage countries to use it. It gives information for planning purposes. And some of the recommendations that came out, obviously we need more midwives. There is a shortage in the region. And also model of care. We promote model of care. Midwives can lead different models of care. For example, midwifery-led care, midwifery-led maternal surveillance and response systems, strengthening midwifery-led self-care, midwifery-led community engagement, and so on. So, but a model around midwifery and quality of care. Fortunately, we have seen some countries have really high skilled birth attendance, but they are unable to reduce maternal mortality ratio. And in this case, we say it's not only availability of midwife, but midwife has to be supported by enabling environment. The equipment has to be there. The system has to function, a referral system, and so on. And also, there is a quality of care assurance process in place. And there is a lot to do in improving quality of education. You know, some countries say there is a huge demand to increase number of midwives. So what happened is quality of the education will not be, the system that reassures quality of education will not perform as it should be. So there should be competency-based curriculum or aligned with the ICM standards, and it should be used by all schools. We also see that data is an issue around midwifery. As you have seen, data is a big gap in this state of midwifery. Data is the only source we have at the regional level, for example, even at global level to work on. And with WHO, there is a work in progress in strengthening the national health workforce account, just like any other health account. Like, for example, the national what do you call it? There is a national expenditure account. We have also national health workforce account system, but that system captures very little about midwives. For example, there is no distinction between nurse, auxiliary nurse, nurse midwife, and so on. All midwives are categorized as one midwife. Those kind of limitation, but this is a work in progress. And midwifery leaders. We looked at leaders. Leaders means those who have position at Ministry of Health, National Ministry of Health, or at sub-national level. I think Kenya is in a good position, but there are some countries who do not have even one person midwife at the Ministry of Health leadership position. So this is all I wanted to share with you, and I think we have come a long way, and the evidence shows that a lot has been changed. There is a positive progress, but a lot remains to be done. With this, again, I would like really to thank you, the organizers, and the UNFPA country office in Kenya, also to invite me to this meeting to share the regional perspective. Thank you so much, and I wish you a very productive deliberation.
Thank you so much, Muna. That is a good highlight, and within the course of our conference, we shall be able to share the action plan for Kenya Midwives tomorrow, based on the deliberations and the expectations of Kigali meeting for East Central and Southern Africa. So we are happy to have you to have given us just a general overview of what is on the ground, especially for Kenya. And so we are sure that we will be engaging within the team and even have your support together with other leaders in Africa to be able to have that. So team, if there are any concerns, issues, questions, we could raise them for Muna to address before we can let her go. Thank you.
Thank you very much, Muna, for that elaborate presentation. Mine was to put up across the issue of midwives being taught by other non-midwives at a higher level. Do you mean we need to have something like the Nursing Council still regulating the midwifery education in the universities and above, or that's the question I wanted to maybe to elaborate on. Thank you.
Okay, Muna, did you get that clearly?
Yes.
Thank you.
Yes, I think so. So I think it's about a choice of a framework that that regulates the health workforce, and there is no harm in the nursing council regulating other health professionals, including midwifery. And as far as I know, there are models of regulation, and one is the Ministry of Health in itself put a body for regulating the health workforce, but others delegate authority to councils, which are mandated by legislation to regulate. Midwifery associations are not legislated by law to regulate the health workforce, but councils, they are mandated. But it's a lesson we want to cultivate in our region by bringing different countries to share their experience. How is the process? How is it started? What are the gaps? What are the challenges in regulating health workforce, including midwifery? So the Midwifery Association, I think in some countries they even have midwifery councils, but very few in our region. I think one or two nursing midwifery councils. They work with Nurse Midwife Council or Nursing Council. But how do we really make our voice heard from the Midwifery Association? It's association who have more information about midwives than the Nursing Council or Nurse Midwifery Association. It's the association who can bring the voice of midwives into the table for the regulatory bodies. But how can we strengthen this function of the Midwifery Association to work closely with the regulatory body, whoever that is? So this is the experience we would like to explore, and I'm sure Kenya will be part of it, but We also invite countries, for example, South Africa and Ethiopia, to share their experience on regulation of midwifery workforce. The Ethiopian regulatory body is the Ministry of Health, the government himself. It didn't delegate to a council. This is one model. The South African has delegated the regulation to the South African Nurse Midwife Council. So we want to bring these two and hear from them what are the processes and challenges and way forward. In that way, we learn from each other. There is no really one size that fits all. I hope I have answered your question.
You've answered partly the question. There seems to be a global challenge on advanced midwife or even advanced nurse practitioners, whereby you have the level of, let's say, the cadre to train this level in nursing. What can we do about them? Because we are having a lot of problem in practice. We have several trained, maybe they go up to PhD level. Some majority are under master's level, but nobody can feel us. Nobody can feel us. We can't do anything beyond, because in other countries they are doing cesarean sections. If you've done your master's in midwifery, we feel you need to be treated like a consultant, like the doctors. Does it mean we are trained at a lower level and we cannot do some of these things in practice? Or what do you think we can do, maybe globally, so that this thing, we should stop, let's say, affecting the nurses? What are we able to do at that level of advanced midwife practitioner? Because we tend to just be doing the same things, and even the regulation, when it comes to practice, you do the same assessments and that kind of a thing.
Thank you so much. Muna, could you want to tackle that? Kindly let's have one meeting so that we can have a clear transmission. Thank you so much for consulting. Over to you, Muna.
The sound is very broken. I'm not sure I get everything, but I heard part of it. Could you repeat the question?
Okay, I think basically to summarize what she's asking is that we have advanced nurses, advanced midwives, practitioners who have advanced their career to master's to PhD level. However, the treatment that we receive in practice is not commensurate. It's not tallying to what the other professionals are given. For instance, the doctors who can do cesarean section, regardless of their level of education. So she wants to know, what can we do? How do we handle this? Because we also want to be felt in that space. Is that what you mean? Thank you. Over to you, Mona.
Yes. I think that's an issue for other countries also. This is a new area we are stepping in, higher education, advanced nursing, advanced midwife, and masters and PhD. And one solution, which was actually is led by WHO, is a Center of Excellence for higher education for midwives. For the midwife, I think the South Africa, we have one Center of Excellence for midwifery education in South Africa, and 4 other countries as well, led by WHO collaboration for excellence. That could be one way of really continuously improving the education, the quality of education, and also opportunities, creating opportunities for improving skills and knowledge and sharing and so on. This is all I can say, but it's, I think, a real challenge for other countries as well.
Hello, Muna. Thank you so much. I think we want to stop there. Thank you so much. I know we've taken a bit of your time, but we want to appreciate you for being with us. So we will give you a round of applause. The Kenyan way. 5, 4, 3, 2, 1. 1, 2. Thank you so much, Una. Our regards to all the midwives.
Thank you so much.
Karibu. Thank you.
Thank
Bye.
you. Thank you. Bye-bye.
Hello? Yes, I know it's time for lunch, and so did you want to go for and take something? But allow us to take 2 more presenters so that is that okay with you? Good. Now let's see how many. I don't know how many. Okay, two presenters will take around 10 minutes. Okay, 10, 20 minutes, and then so that we are able to finish earlier. We want to finish earlier to allow us to go and enjoy ourselves out there. So can you just sacrifice another extra 20 minutes? Is that possible? Yes, we want to finish a bit earlier. Thank you very much for your patience. So the next presenter here, please, is Lamek. Lamek Otieno, where are you, please? You should be on the stage to save time. And with the Frederick Nundu, where are you, please?
1 minute. KMET is Kisumu Medical and Education Trust, but we are now beyond Kisumu. It's a local NGO. It started as a local NGO, that's why it was Kisumu, but right now we are beyond that, so it's just a name as KMET. Secondly, I want to say that with donor funding, it's more of restrictive where you want to operate. And that is why we are now working with the Division of Reproductive Health, because this is an essential service. We are now working together and rolling out a mentorship program on management of PPH and all other, you know what the mentorship manual has. So all the partners that implement on MNH, we are together in this, and I think the DRH will announce to you in a good time when we are coming to your county. So I think the next training is for Kisii, Kakamega, Homa Bay, and PSK, Narok. So they have a program. So I think that is partly what the government is doing to bring everything on board, or every partner on board, so that we can see how to manage our mothers and bring down the maternal mortalities. Lastly, I concur with our brother here, I'm sorry I don't know your name, who said that we must take the Band-Aid with us. Most of the counties that we have interacted with are making use of the funds that they have to make their facility ready. They are buying the UBTs, they are procuring the anti-shock garment. Bungoma is an example, Migori, and recently I read about Migori's statement on maternal situation. Their maternal mortalities had come down. And it's because they embraced the bundle approach, where from the gynecologist is the head of the team. So if we embrace teamwork with the little resources that we have as a county or as a facility, we can still bring down maternal mortalities. And then data. Our keynote address speaker has talked about data. We may be saying that it is high and it is not. So if we do good documentation, then we are going to know where are we as per the maternal situation. Thank you.
Yes, asante sana for your response. And so the two are actually students at Kenyatta University. They have a presentation for us. One is a medical student, the other one is a BSN. You are a BSN? These ones are medical students. Very welcome.
Good afternoon. My name is Lamek from Kenyatta University today, you've been told. Before I begin, I must say that I'm very happy to attend this conference together with my two lecturers, that is Eunice and Tekla, and together also with my and with my clinical instructor, that is Naomi Mutiso. So, and all lecturers who are around and teachers, let me be the first person to greet your brother, wish you happy Teachers' Day. Yeah, so on this presentation, I want us to notice that it was a multidisciplinary presentation that was done among the nursing students, medical students, and pharmacy students. And with me here, I have my co-presenter, Frederick, from the School of Medicine, 5th year. So we'll be presenting together with him. So our topic was assessing provision of psychological support among women receiving post-abortion care in the reproductive health unit at Thika Level 5 Hospital, that is in Kenya. So these are just some of my co-researchers and the research supervisors. So on the background of this, you notice that post-abortion care package include the services that are being offered to women who have undergone miscarriage or an induced abortion. So you notice that abortion is described as termination of pregnancy prior to 20 weeks of gestation, according to WHO. On the background of this, you notice that globally there is around 73 million abortions that take place yearly. And in Africa, when you come down to sub-Saharan, we have around 6.2 million per year. So when you come to our setting in Kenya, I noticed that we have around 464,000 induced abortion cases. That was according to the research that was done in 2012. We've not had any other research done between that period up to now. And why is this a problem? So you notice that abortion causes complications of stigma and physical trauma of pain among women. Also, these women undergo psychological problems. And you notice that in the community, or rather the friends and people around, ostracize or label these women, and they feel stigmatized as murderers or prostitutes. And you know what that translates to the mind of a person. Maybe they have feelings of guilt and may lead to suicidal cases. So also that you notice that all women who have undergone abortion, whether induced or spontaneous, they are entitled to receive a comprehensive pack, that is post-abortion care package, but psychological support is rarely implemented. Now objectives, so we had the specific objectives there. One was to assess the components of PAC that were provided in the unit. Another one, you wanted to know the level of provision of the psychological support in the unit as a component of PAC. And again, the personnel who is involved in support. And lastly, the perception of women, the women who have undergone abortion, regarding the quality of psychological support that they were being given. So on the materials and methodology, this was a descriptive cross-sectional study design. It was only one variable. However, we did study on the different components of that variable, that is components of PAC, level of provision, personnel, and the perception of the women. The area was in Thika Level 5, Reproductive Health Unit. Again, and study population include all females or women in the Reproductive Health Unit, specifically, that was in Ward 6, Gynecological Ward. Inclusion criteria involve women of reproductive age who had received PAC in the unit, and also the healthcare providers who were found in the unit. Exclusion, women who did not consent to this study were not included in this study. And the sample size, we had around 53 participants. That was calculated using Yamane sample formula. This sample was conveniently distributed to 19 participants as questionnaire, then 10 focus group discussion, and we also did a file review, a 24 file review. So data collection, as I've mentioned that. Then on the analysis, being a qualitative study, we used descriptive and thematic analysis. And of course, we got approved to conduct our study from the KU Ethical Review Committee and Thika Ethical Committee. And again, we also maintain the confidentiality of these study participants using anonymity of the participant. We never disclosed their names while doing the study, and we ensured that all of them conducted, signed an informed consent. So on the analysis of all the research findings that we came up with, being a qualitative study, we did, we conducted what we call, we did thematic analysis. So thematic analysis were done under the objectives. So under objective 1, which was components of PAC, major themes that were coming out from that, we noticed that we had medical care and psychological support. And under medical care, we noticed there was surgical care, pharmacological care. And under surgical care, mainly there was MVA that was done, and many patients also responded that they received antibiotics, pain reliefs, and family planning services. And also a few of them mentioned that they got debriefing, counseling, and education. So when you go to the file review that we had, you notice that between the months of May, April, and March, when you check under the column, so we had the components here that we found documented in the file. So family planning, provision, family planning, counseling, and psychotherapy. So we noticed that psychotherapy, where the psychological support falls in, was under the column of no, meaning that it was not given. So, and you can check the trend is in the month of April and again in May. So what was the conclusion here? What was being given in the unit was actually family planning, counseling, but not really the psychological support which these women are supposed to receive. That was our conclusion on under that, the components of psychological support given. So having said that, allow me welcome Frederick to continue with the few that is remaining.
Hi, my name is Frederick Kotieno Nundu, student MBCHB level 5, who did this in a multidisciplinary study with my friends that you have been informed, and I'm grateful to be part of this presentation and to be part of you. So I'll go straight ahead. On the level of provision of psychological support, here we are assessing how they were grading the way the healthcare providers were providing the services for psychological support, and we graded them as either high or in a moderate or low. And participants who were of the opinion that the psychological support was given was at a high level, they said it was engaging, it was encouraging, and they quoted the providers are highly skilled. Those who say it was moderate, they quoted that they need to improve, especially in counseling. And those who are of low opinion, they said it was poor counseling being provided. So you can see that majority did not receive any form of counseling before and after the procedure. And this one was after an in-depth analysis and talking to the patients. And I can quote, they are saying there was no counseling, hence I cannot comment. This was when we asked them if there is counseling that was given. And the one says there is no counseling. One was asked how she was feeling and was taken to the room there. They were pointing at the MVA room. So we realized that at this one was the opinion that nothing was actually given to them except being asked how they were feeling. Some reported that counseling was given, and when we probed them further, we actually realized that you can see, well, I can quote, I was counseled to use family planning, and that we were expected to choose which type of family planning. So we realized that this one is accepting that there was counseling being done, but when we try to find out what is this counseling that's being provided, they're actually telling us that it was actually family planning and it was not psychological support. This further revealed that actual counseling is given is on family planning, which shows a disconnect between what the patients are receiving as counseling and what the healthcare providers were answering or were telling us that they were providing. We also went ahead to ask them about the personnel who are offering psychological support. It said that all the healthcare providers admitted that they were providing the psychological support, and these ones we We actually talked to the doctors, the nurses, the clinical officers in offering the counseling. However, nurses were found to be more likely to provide psychological support because the patients, whenever they had a question, they were asking for help from the nurses because they were easily reachable. So, however, the information may have been, so we also asked them if they were certified, that is the personnel who was offering these services. We asked them if they were certified in the course of provision of psychological care, and they all said that they were actually certified, although this information could have been biased because there was no proof of certification. The patients say that the staff were actually very well skilled, and some of their peers, however, did not feel the same. You can see, for example, a participant is saying the staff had excellent skills and encouraging and engaging during counseling. A second participant is saying, I did not feel contented after counseling. The first impression was poor, and I was not happy about the approach used during counseling. Another one said they are not friendly. They did not build a rapport before proceeding with the counseling. And on their perception of these women who are receiving psychological support, how were they perceiving this kind of care? So some perceived the process as satisfying and described it as engaging, excellent, and they were advised on the procedures. They were actually debriefed. So you can see one say the staff have excellent skills, they are encouraging and engaging during counseling. However, a majority perceived that they were less satisfying, they were poor, they felt pain in the course of the provision, for example, of the my MVA, and they were not contented. Another participant said, I can quote, I had a family planning method, that is IUCD, and got pregnant. I don't understand. I actually didn't know I was pregnant. No one took time to tell me what happened, how I got pregnant, and here I'm going home. So in conclusion, in our conclusion, we found that psychological support is actually highly neglected as a component of post-abortion care in the unit, and when provided, it is actually confused with family planning counseling. The level of provision of psychological support, according to the way the patients were answering, is low and compared to the components of PAC. All the healthcare professionals in the unit are actually involved in psychological support. However, the nurses were actually found to be providing counseling than other professions, and the services that were offered were psychological support do not satisfy the needs of the clients. At this point, I would like to give the recommendations that there should be a healthcare personnel who are solely dedicated in the unit or in our reproductive health unit to do specifically these works, and they need training. There should be a standard guideline that is so that they do not confuse psychological counseling and just counseling for the sake of it, or giving reproductive health counseling. So the documentation was also supposed to be done if counseling was done, and they were supposed to specify if they did psychological counseling or family planning. We further we further recommend that the study barriers on the provision of psychological support provision is supposed to be provided. At this point, kindly allow me, please, to appreciate THICA Level 5, the THICA Level 5 management, Dr. Munyendo, who is the medical superintendent and was also involved in allowing us and taking us through the processes. Special recognition to the reproductive health unit. Kindly, Madam Naomi Mutiso, I know she's here. We really appreciate you, the in charge of the reproductive health unit, the GYN ward. Thank you very much. Kenyatta University, in general, and especially the Dean School of Medicine, Dr. Ongecha, School of Health Sciences. We really want to appreciate you very much. We want to appreciate all of you, the Midwives Association of Kenya, giving us students this opportunity to be here, to talk to you, to present to you. We cannot take it for granted. Thank you very much. We really appreciate you. We love you so much. And finally, even as an individual, I can go ahead and I would have recognized everybody. Eunice is here, Tekla is here. I really appreciate you all very much. And for you midwives doing a great job, me as a medicine student who's supposed to be a doctor, we are taught by you to do deliveries, because our consultants are not there where I'm supposed to be good at my work, but where do I get the skills? The consultant is busy. If it was not for the grace that you have for us, how would we have learned to do vaginal examination, check the perineum, and all that? Thank you. God bless you. I really appreciate you. Thank you. Thank you.
Okay. Hello. Hello. Yes, thank you very much, the incoming Daktari and the BSN student with Lamek for that wonderful presentation, actually. And I think we are happy that our students are doing well. You are the future researchers in this country. And for recognizing midwives, actually, the nurses in this, actually, the one actually train the doctors in this country, okay? Before they become consultants. Unfortunately, when they become consultants, they look at us like right. We are being reminded to register. We are being reminded to register for the gala night, and I wish I was a Songo in town. I would have actually promoted all of you, but I'm not a Songo. I would have actually, registered all of you with 1,000 above. But you can pray for me in the next 10 years. If I get money, I'll be sponsoring you. That's wonderful. Now, the next presenter. So, can you upload the team again before once again? The next presenter, Paul, is actually Sharon Mamanyi. This has been our student at JQuad. She's now currently pursuing a master's in epidemiology at the same university, and she's doing her internship at Moranga County Referral Store. So, welcome, Sharon.
I hope you can all hear me. I am Sharon Mumanyi, and I'm very happy to be here. And I'm glad I've seen the Happy team here. I was mentored by Happy to be a researcher, and also my amazing mentor, Caroline Yareki. So I'll go straight to my research on determinants of early marriage among girls aged below 18 years in Rwanda slums, Nakuru County. I am from Nakuru, and I do understand the plight of these young girls. So I'm not going to talk about the other early marriage that we know, where girls are exchanged for cows, but we are talking about girls themselves getting married because it's their decision. So early marriage is any marriage that involves girls below the age of 18, and globally it has affected over 650 million women, and its prevalence in the sub-Saharan is as high as 54%. Kenya is also ranked 20th in the prevalence of early marriage, and here in Nakuru the case is no different because it's very prevalent. 3 out of 10 marriages that occur are child marriage. So, so in our constitution, it's normal that they're saying that a person shall not marry unless they have reached the age of 18 years. But in the low-income communities, this is contrary because girls are still getting married, and this is a form of child abuse. So, as I've said, the child marriage prevalence in Kenya is 23%, and Nakuru right now is a city. So, compared to other cities in Kenya like Nairobi and Mombasa, its prevalence is as high as 15.3%. Why am I talking about girls? Because the only percentage of boys who are affected by early marriage is only 1%. My research questions were to look at the social and economic determinants of early marriage here in Rwanda slums, Nakuru County. So I have my broad objective and specific objectives to explore the determinants of early marriage and to explore the social and the economic determinants of early marriage. I had my conceptual framework there. So it is a qualitative study, and the research design that was used is the qualitative phenomenological study design. Our study area was here around the slums in Nakuru town. Our study population are all the girls who are married below the age of 18. Our sampling technique, since no girl can admit I am 15 years. So we did a snowballing sampling where one girl will lead us to another. We recruited until data saturation, so those were 15 girls. Our inclusion criteria was all the girls affected by early marriage. Our exclusion criteria were girls that were, some of them were mentally unstable. So the data collection and analysis, we collected data using an interview guide with 8 specific questions. The responses from the clients were tape recorded and were analyzed using a thematic analysis. Our ethical consideration I got from the Nakuru County Health Department, the JQuat ERC, I also obtained informed consent, and because these girls, some of them are below the age of 18, I obtained assets. The results, the current age of girls as at now when I was taking the data, the average was 20, with the oldest being 25 and the youngest 16. But at the age of marriage, the average was 15, the youngest 15, and the oldest was 17. All 15 only attend primary education. This shows that education is still a challenge. So I organized my themes into this table. It's a summary: the social factors, economic factors, sub-themes, teen pregnancies, poverty, and the specific categories under each sub-theme. The results. So 10 out of 15 girls say that their reason for early marriage was teen pregnancy. I won't go ahead and read every response. You can take a look at this research because I understand we do need to eat. So you can take a look at this research later on and see the clear responses of these young girls. So another thing about was the family planning and safe sex. All 15 did not know about family planning and safe sex, which is very sad. Some of them came to know about this after they've had 5 children or more. Another something was societal beliefs and practices. We are protecting family honor, where some of the girls think, let me get married so that I cannot disgrace my family. And we have economic factors such as poor living standards and denial of education as another subtheme. We had large family size and financial restrictions. Conclusion, so what? So we are getting married, so what? As midwives, I've heard someone saying about the policy, the first presenter, I believe, about policies and contraceptives, that there's no way we can give young girls contraceptive if the policy says otherwise. But we forget that we are the basis of policy making. Midwives are the ones who can push this policy, and we can be heard and help these young girls. There's no way we can have a 15-year-old girl with 5 children and we're still denying this girl contraceptive on the basis of a policy that we can change because we are stakeholders. I was having this discussion with the nurses on tea break, and many of them supported that a policy needs to be changed. So poverty also plays a role, and girls view marriage as an escape from poverty. Poverty denies girls education, and education is not really held in high regard. So I've already mentioned some of the recommendations, but I want to add, because you can see that some of them, societal shame made them get married. And we are human beings, and I know we can help eradicate that. This is by ensuring that if a girl is coming to deliver, if a girl is coming for ANC and she's pregnant and she's only 15 years, it is only logic and only right not to judge this young girl and say, Bono kona mimba at this age. It has already happened. It is our role to challenge ourselves, then talk to these young girls in a very humble and in a good way. Tell them it has already happened. It is okay. How do we move on from this? Pregnancy is not a disease, right? It is only a state. So I believe we can all help these young girls by communicating to them, being mothers, being fathers, because midwives are not only women. Those are my references, and thank you very much.
Makofi kwa baby girl. Pregnancy is a state, sindio? I think at this time, we shall go for lunch. Simumesaik. Ama we can still change condition. Labor to continue, sindio? We're prolonged, so we shall go for lunch, then we come back, and then maybe we can discuss at that time whether we'll have the plenary for the ones who have presented after the first ones. Sawa sawa. Situombe hiyo chakula. Ama it's not important. Wacha tuombe. Mfunge macho, hakuna kuku hapa. Okay, Heavenly Father, in the name of Jesus Christ, we come before you this afternoon with thanksgiving. Thank you for the fire you brought us King of Glory, we have food before us. We don't know what it is, but we are sure you are going to bless it for us. We thank you and we honor you. Remember the ones who do not have food at this time. Father, provide for them. We pray, trusting and believing in Jesus' name. Amen. Oh, dakika ngapi? Oh, the dinner. Please remember the dinner. The dinner gala. Wale wametangulia. Karatasi iko hapo kwa hiyo meza ya registration, please. Wacha tufanye hivyo. How many? 40 minutes, please.
Wakufuma tumefuma, wakukosa umekosa. Wakufuma tumefuma, wakukosa umekosa. Sadakta, umepata sadakta. Sadakta, nimefanikiwa sadakta. Sadakta, umepata sadakta. Sadakta, nimefanikiwa sadakta. Ikawa amba, wewe bado unagomba, kipi kikusumbua cho jambo? Macho yako kama mamba, wala hujui kufumba, akikupiti kitu kirembo. Umesikika wa amba, wewe bado unagomba, kipi kikusumbua cho jambo? Macho yako kama mamba, wala hujui kufumba, akikupiti kitu kirembo. Japo mie sijatamba, wala sio kujigamba, lakini sifichi langu pambo. Kasirika sasa vimba, urejua hutaziba, wewe jifunze ujue mambo. Japo mie sijatamba, wala sio kujigamba, lakini sifichi langu pambo. Kasirika sasa vimba, urejua hutaziba, wewe jifunze ujue mambo. Endelea kunichimba, nenda kwa wachawi omba. Endelea kunichimba, nenda kwa wachawi omba. Jua Mungu hapigi kwa fimbo. Jua Mungu hapigi kwa fimbo. Adabu yako elewa, nimefanikiwa mie, nimeongokewa mie, nimejaliwa mie. Unaona fi, uniona mie kung'aa, siachi, 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 siachi. siachi, mie siachi. Unaona fi, mie kupanda rafo, siachi, 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 kupanda rafo, siachi. Unaona fi, mie kwenda melodi, siachi, 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 kuna melodi, siachi. Wataka kuliziba jua na ungo, huwezi kuliziba jua, huwezi kuliziba na ungo, huwezi kuliziba jua, huwezi kuliziba. Wataka kuliziba jua na ungo, huwezi kuliziba jua, huwezi kuliziba na ungo, huwezi kuliziba jua, huwezi kuliziba. Milango uliofunga, gonga misumari, gonga, fanya ukuta ujenge pia. Weka mtu wa kuchunga, utaniona kusonga, sasa Mungu kanifungulia. Milango uliofunga, gonga misumari, gonga, fanya ukuta ujenge pia. Weka mtu wa kuchunga, utaniona kusonga, sasa Mungu kanifungulia. Ulie ukiningonga, don't run, Murife, don't run. Dilikia jahazi kutoka Maka, kwangu limetia nanga, neema sasa nazilalia. Ulie ukiningonga, eti miwa moja kanga, aliisha nibadilikia. Jahazi kutoka Maka, kwangu limetia nanga, neema sasa nazilalia. Hebu domo lako funga, kwangu mimi utachonga. Hebu domo lako funga, kwangu mimi utachonga. Jua Mungu ameshanilipia, jua Mungu ameshanilipia. Jaza yako elewa, nimefanikiwa mie, nimeongokewa mie, nimejaliwa mie. Unaona fi, uniona mie kung'aa, siachi, 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 kung'aa mie siachi. Unaona fi, mie kupanda rafo, siachi, siachi, don't run, Murife, don't run, rafo siachi. Unaona fi, mie kwenda melodi, siachi, 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 kwenda melodi siachi. Wataka kuliziba jua na ungo, huwezi kuliziba jua, huwezi kuliziba na ungo, huwezi kuliziba jua, huwezi kuliziba. Wataka kuliziba jua na ungo, huwezi kuliziba jua, huwezi kuliziba na ungo, huwezi kuliziba jua, huwezi kuliziba.
mwali anamelemeta leo gogo, sifa ninazopata asile inaozesha leo.
Baba harusi ongera,
ndoa ni jambo kubwa mwanangu, kaitunze heshima yangu, chozi linanitoka mwanangu,
olewe
siamini macho yangu. Babu harusi mshike taratibu, usije ukafuta piko. Haraka ya nini wakati huyo ni mali yako yako? Mwanangu checheme, ulofundwa usiseme kwa watu,
usungo
maneno umumunye ya chumani, usiwape faida watu. Mwanangu
You're listening to the Nigerian Overdose Mix, mixed by the international DJ, DJ Shinsky.
Sugar cane sweet, but your love is sweeter. So
bubble of juice mixed with a little ginger. Oh girl, I wanna be with you, but you know they got enough time from me. I wanna live with you. I got the reason why I can't let go. Girl, you never know, so you gon' gas up. Man, them so far to find your love. Girl, you never know, so you gon' gas up. Man, them so far to find your love. Girl, you never know, so you gon' gas up. Man, them so far to find your love. Girl, you never know, so you gon' gas up. Man, them so far to find your love. Man, on your chin, now girl, don't talk. Coming like a thief in the night, long jaw. But you know, say, ain't no more them ball. Nothing you go ever need at all. Man, on your chin, now girl, don't know. Taking it a break, and then me, I know the rush. Baby, if you want me, catch a rebel, but me say without me. Yeah.
Show me a jigger, let me see. Let me see. And let me see the woman that is with. Put a couple $1,000 on your wrist. What's on your wrist? Mama, they can't touch you. I ain't never see this kind, babe. We do some kind things, make me feel some kind way. You know I'm not just trying
in this initiative. Number one, constant reminder of pregnant mothers increased their understanding of the importance of the visits. Number two, central management of pregnant mothers data enables the program officer, that's RH, to closely monitor mothers' visits in order to identify special needs, even mothers at risk. I know my time is up, but just 1 minute so that I can say our recommendations and challenges, and then I will be nitakuwa namalizia. Sometimes CHARs and CHVs were given wrong phone numbers. That was one of the challenge that we have, but we usually correct that. Erratic financial support by counties, and some mothers were usually out of reach on phone. Unapata ni wateja, but we use the physical location that is in the database. Our recommendations are these: constant and steady support by county governments to actualize the major goals of these predims, and replication and scaling up of predims to other sub-counties can give out a positive yield in terms of increasing in our data that our targeted RAMCA data. So, and because this will give you a serious information about first NCs, and it will even help the facilities in planning. Very predictable. After calling those mothers, we have got a predictable program. Facilities hawakai tu wanashtuliwa na mama akija mjamzito. Hapana, wanajua ya kwamba kuna mama fulani ambao nitakana wakuja, so they do their planning. It really helps us in planning. So this is a quote that I want to say, that remember that we as midwives, mediocrity is doing the same thing, using the same means, expecting different results. So let us all think without box and not think out of box. Thank you very much, and may God bless you.
Thank you, Dominic. Thank you for the good presentation. We do a lot of stuff, same status quo, expecting great results. Take home message. We have Sophia. Sophia? Is Sophia in the house? Karibu, Sophia. Sophia Kirinya is a BSN, KRCHN nurse midwife with over 5 experience in clinical and community health nursing midwifery. She's currently working at a level 2 health facility as a facility in charge in Kakamega County. Her low cost of high impact sustainable intervention at the Sinoko dispensary during the COVID-19 pandemic was awarded the Margaret Kenyatta Beyond Zero Nurse Lead Initiative of the Year finalist. Kindly let's appreciate that in 2021. Thank you, Sophia. So Sophia will be taking us through the initiative that saw her get that award from the Margaret Kenyatta. Thank you so much. Very good.
Good afternoon. Thank you so much for that introduction. As you have heard, my name is Sophia Kananu Kirinya. Yeah, you have heard a lot about sub-counties, hospitals. I'm here to present a case of a dispensary, a level 2 facility. Yeah, as we all remember, during the COVID-19 pandemic, a lot of services were really disrupted. So as a facility, we came up with the baseline interventions that were nurse midwife-led interventions to improve, to strengthen the services at our facility. So it's a nurse-led community-based intervention to improve access and utilization of reproductive, maternity, maternal neonatal healthcare services during the COVID-19 pandemic, a case of a level 2 health facility in Kakamega County. It was a teamwork Sophia Kirinya and Jemima Simiu, who did not make to be with us today, but on our behalf, I'm going to present the work that we did. So I'll take you through introduction, methodology, results, and the conclusions. In 2016, WHO implemented a lot of packages of interventions in the community and the household that can help in improving access and utilization of reproductive maternal health services and the outcome, particularly in the rural settings, where we really find that where the level 2 facilities are found. In Kenya currently, the maternal neonatal mortality rate is still high compared to the SDG targets. So as a facility, we came up with interventions during that COVID-19 that could still help us strengthen the service delivery during the pandemic. As there was a lot of worries when the pandemic struck, people thought that the services would be interrupted. So midwives and the community and the low-level facilities, for us to achieve universal coverage of services, you have to come up with a package of interventions that will help us reach the hard-to-reach populations where the community really finds hard to reach the facility. So, COVID-19 disrupted access and utilization of reproductive, maternal, and health services, not only in Kenya, but globally. So, we strengthen community health strategy to sustain demand, to create demand and sustain skilled birth attendance, family planning, immunization, and IMCI. So in our facility, we evaluate these studies to evaluate, it's a case to evaluate how a nurse, midwife, and community-based interventions can help scale up, can also continue to strengthen the antenatal immunization and family planning services in a level 2 facility. So, you remember in March 2020 is when we had our first COVID-19 case. So the intervention started a month later, that was in April 2020, due to the restrictive containment measures that the MOH had to put in place to contain the pandemic, which were the lockdowns and the curfews. So despite the curfews, the services could always continue to be sought in the facilities. So these interventions were to continuity of the service in the facilities, especially now that we have the containment measures from the Ministry of Health. So we started with the line listing of immunization defaulters and the antenatal defaulters, and then you develop a MCH weekly work plan, and then mobile phone tracking of the immunization defaulters. That is, you make a phone call to these defaulters, and then the CHVs had their interventions which were to do the mapping of the community in the community, and that through doing the mapping, they could identify those and create demand for antenatal, family planning, and immunizations. Secondly, they do door-to-door to defaulter tracing by the CHVs. The design used in this study was a before and after design. That is, we compared the period of when we didn't have the COVID-19, that was in April 2018 to March 2020, and during and after the COVID, that was in April 2020 to March 2022. So it was a study of comparison of the achievement between those two times, before the COVID, during COVID, and after COVID. So the site of Sinoko Dispensary in Lukian Sub-County, the time was a 2-year period coverage. That what I said, April 2018 to March 2020. During and after COVID, that was April 2020 to March 2022. The variables of interest here were the coverage of family planning, the coverage of antenatal care, family planning, and immunization. The data was extracted from Health Information Health System and compared with the primary tools, that is the 7, 10, 7. Continue. Sorry for the interruptions. So on the result, now you're on the ANC coverage before and after the before COVID-19 and after the interventions. As you can see, you're first on the ANC coverage. We look at the first ANC visit. Before, we are still doing good, yes, but there's a magnificent increase of around 30% after the interventions. The same case which applies to the fourth ANC coverage, where we were at 89.2, and after the interventions, it is shot to 117.3%. That shows the interventions done during the COVID, despite being a COVID time, they were a blessing in a disguise to our facility. On the immunization coverage, here we looked at Penta 1, Penta 3, and MR1. So you realize in Penta 1, we are still doing our targets well. That what before the COVID, we are at 100.4%, but after the intervention, we shot up with around 30% of the achievement. The same case to Penta 3, but with MR1, the result was so magnificent to an extent that we shot by 50% compared to the last time before we had the COVID. With that all going up like that, the droplets of all the Penta 1 and MR1, they also dropped, which shows it was a positive outcome from the interventions done during the pandemic time. Family planning. Here, in the family planning, we have 3 bars that shows different things. One, here we didn't use the proportions. Here we use the mean, because in family planning we don't have targets. So you realize in family planning of women of reproductive age who are seeking services for FP dropped. Reason being, during the pandemic, the worries were so much, so the clients saw that when they come to the facility, they'll get COVID-19. That's why you realize the new cases of the revisit and the number of women attending family planning went down. But when you look at the short-acting method, the mean went high. Why? Because during the pandemic period, there was a lot of things that happened. Many of the clients now, many people lost job and went back home. So they wanted to sort an emergency way of how they can prevent themselves from unwanted pregnancies. That's why you realize the short-acting method went higher than the long-term, meaning that when you are administering a long-term method, the time to convince a client is very high, but when you're giving the short-term, it's low. And they have the worries of getting COVID-19. So they prefer the short-term than the long-term. The short-term here we are referring to the Depo-Provera injections, the combined contraceptives, the HIP pills, and the progesterone. Are we together? Conclusion. Here, you realize the interventions done were of low cost to the facility and they really helped us in improving the target because we were able to reach the remote and communities. So what are our recommendations as a facility in Sinoko Dispensary? The counties to prioritize integrating facility and community health strategy interventions to achieve universal health care for maternal and child health service in hard-to-reach areas. So, acknowledgement goes to the Sinoko World Healthcare volunteers for the great work they did, and the Rikuyan Sub-County Health Management Team and Kakamega County for their continued support and the funds. As you can see from the photo, there's a group of pictures there. That is part of the team that led to this work to come out where it is. The photo? Yeah, there's a photo there. That is the team that we worked with. I can't go without mentioning my mentees of this work, Jemima Simiu and Duncan Shukuku.
Thank you, Sophia. I think she deserves better. Mumezima stima kukanyesha, but she still stood strong. Sindio? And we appreciate you, Sophia, for the good work. I can see we're still managing time well. I'll be calling upon Mercy from JJ. Mercy ni partner, one of our great partners. We've worked together as MAK with JJ. is consumer health, covers sub-Saharan Africa. She's been a very great supporter for the midwife and is always present in our conferences. I guess she'll be able to tell us more about herself. Thank you.
Good afternoon. Because of time, I won't tell you more about myself, but it's Mercy or Marceline Care, and J&J is telling me to say it's Johnson & Johnson, not J&J. Okay, okay. I know you know me for baby products, but today I'm going to divert from baby to oral health. The people who visited my stand have some experience, and I'm sure you're feeling fresh. Are you feeling fresh? The ones who've tried the Listerine mouthwash? Yeah, you're feeling fresh, kabisa. Yeah, you should be feeling fresh like that every time. So oral health, myth or fact? There are more bacteria living in your mouth than people living on Earth. Is that a myth or a fact? Yes, we are 7.8 billion people on Earth, about there, but we have around 20 billion microbes. Some good, some bad, some very, very harmful. Okay, another fact, myth or fact, untreated oral disease only affects a very small percentage of the world's population. That's what, a myth or fact? Myth, yeah. Actually 50%, more than 50% of people are affected one way or another. There was a global study by the Global Burden Disease that was done in 2010. The research was done for 300,000 people, and the results were actually 11.2% of people globally suffer from oral disease, and especially periodontitis. Okay, so that is a huge number, considering that we are dealing with issues like TB and malaria and things like that. So these are kind of some of the problems that people suffer with. That is cavities. I won't go into details. Gingivitis, which is gum inflammation, and untreated gingivitis end up being what? Periodontitis. Periodontitis, I'm sure you know that, but it's a formation of a pocket on the gum. I'm sure you've seen people with that. The gums that have spaces, and the spaces are filled with some content. Okay. Yeah. Okay. And how does it affect? Why my headline was oral health is a healthy mouth equals a healthy body. How is this connection? So the connection is that if you have we normally get injured on our mouth when maybe you might be brushing or eating something or going through a dental procedure. And if your gum is injured and you have definitely oral bacteria, some of that passes through your bloodstream, goes to your blood, pumped all over the body. So, and you end up having, I was watching a clip that some surgeons actually say they have found oral bacteria in legs. So that's why we're saying your healthy mouth is window to a healthy body. And how do we do this, and how do we make sure that we maintain a healthy mouth? And I'm sure all of us brushed this morning, isn't it? Isn't it? And some of you are going to brush in the evening. I wish I was doing this in the morning. I'd have done a demonstration. Saizi nikifanya mtasema masi tumekula lunch. So I won't go into it. Normally we ask people to pass their tongue on their teeth, and immediately after brushing, you actually feel some build-up. So immediately after you brush, the build-up starts. 3 minutes after we brush, the build-up starts. So we need to keep on taking care of our oral hygiene. And if I was to ask how long do you brush your teeth? A research said most people think they brush 2.5 minutes, but actually majority of people brush 1 minute. Majority of people, and the brushing may not be done well. People there are ways of brushing, proper brushing, and at times we just push the brush where we can see. Okay, but is that enough? Even with brushing twice, research tells us brushing actually takes care of 25% of your oral hygiene. So kama umepiga mswaki leo asubuhi, even if you're going to brush again in the evening, it's only 25% you're covering, because you're covering your frontal teeth, and where your brush does not reach behind, your brush does not go through there in the teeth. Does it? Does your brush go through your teeth? It doesn't. So you've only covered 25%. I wanted you to be shocked, so that when you brush, you know you've actually not done enough. So why use a mouthwash? So again, since the brush does 25%, a mouthwash being liquid goes where the brush does not go. We actually, one of our slogans says Listerine goes where your brush does not go, to kill the germs. I have a few minutes, so I'm rushing through. So the good dentists tell us we have to do 3 steps. These are the golden steps that we are told by dentists. 1, brush twice a day. 2nd, floss. I don't know how many people floss. 3rd, rinse. Those are the golden rules. Brush, floss, rinse. And we say, if you can't do the 3, please do at least 2. Okay, and that's where Listerine comes in. Listerine is the global #1 mouthwash, and it's not J&J saying, it's a world saying, and that is not even our star. That is a star that we've been given. We are global #1 mouthwash. So some of the mouthwashes use, we call them colored water and not mouthwash. This is what Listerine is made of. It has eucalyptus, and it has menthol, it has thymol, it has menthol salicylate. All these are essential oils. So these are the basic products in all our Listerine. And then that is the range. You have a wide range. So, and I'm seeing my time is up. So I'll just go through this faster. We have the purple one. We call it Total Care. That is the most complete mouthwash we have. And then we have Total Care Sensitive for people with sensitive teeth. If your teeth are sensitive, this is what you should go for. And then these are basics. Come to the stand. I'll give you more details on that. And then we have Listerine Zero. Listerine Zero is actually does not have alcohol. Our other Listerine has alcohol. So Listerine Zero has no alcohol, and that's what we want you to take. This is the message we want to take you to take to your pregnant moms. They can use Listerine confidently, especially Listerine Zero that does not have alcohol. And this can also be used by people who have issues with alcohol, because you don't want them to use the one that has alcohol. And religious people also who are concerned about use of alcohol can also use Listerine Zero. Yes. Okay, so I want to give somebody I like giving out present. I want to give a present. Name 4 essential oils found in Listerine mouthwash. I showed that. Who want to try? And 4 of them. It won't help. 4. And if you can't, I'd rather who want to try? At least 3? Yeah. Okay. She's the one who, you're getting a Listerine. You come to my desk, I'll give you a Listerine. Thank you very, that is what they have. Thank you very much. For more information, please come to the desk. We talk some more.
Okay. Thank you, Mercy. Thank you. You know, at one point when she said, rub your tongue, I know everyone tried. I'm sure we all did that, kisiri-siri, and then you realize it's lunchtime, you have just had your to maskuma hapo. So as you're rubbing, you realize there's so much solid. So don't try it right now, try it at home. This is one thing we say, try it at home. So our next presenter, thank you, Mercy, for that. Our next presenter is Violet Akisa. Violet. Yes. Violet Akisa, Alari, and 2 others will be presenting to us association between antenatal syphilis and low birth weight in Webuye County Hospital. Violet Akisa is a senior midwife with 20 years experience, a KRCHN with senior management experience in youth-friendly, a CSC trainer, park mentor, and a facility GBV coordinator. Together with Violet is Esther Ahono, a KCRHN, nurse midwife with experience of many years. Ni mingi yo miaka. She's an EMONC trainer. She's a facility deputy nursing officer in charge. and she's the MPDSR coordinator. So we give this chance to Violet and Esther to take us through. Karibuni.
Good evening. Yes, I'm Esther Ahono. I'm going to take part of it, then we'll to be able to complete the remaining. So the background, globally nearly 1 million pregnant women are estimated to have syphilis annually, which is estimated to cause more than 350,000 adverse birth outcomes, accounting to 200,000 stillbirths and newborn every year. That is as per the WHO February 2019. Worldwide, the prevalence for antenatal syphilis is 1.7%. More than 90% of these infections occur in resources-limited setting, that is Saraj Hussein 2017. In sub-Saharan Africa, it's estimated to be 2.7%, that is Blanco 2019. In Kenya, the prevalence of syphilis in women attending antenatal care is estimated to be 3.4%, that is KIC 2017. According to the fact sheet survey conducted by the World Bank, September 2022 shows that the prevalence of syphilis in antenatal mothers 0.3%. Significance. Congenital syphilis remains prevalent in many low and middle income countries, LMICs, yet it's preventable. Elimination of mother-to-child transmission of syphilis is achievable through routine screening and appropriate treatment in pregnancy. Thus, testing for syphilis is mandatory in pregnancy. Uptake of testing is poor. The stock out of test reagents is common, and testing is conditional on attending antenatal care. The study will shed light on the effects of antenatal syphilis on pregnancy outcomes and inform on the possible interventions. Objectives, broad objective, to determine the relationship between antenatal syphilis and adverse pregnancy outcomes. Specific objectives being to describe the prevalence of antenatal syphilis in relation to the timing of the antenatal visit, to determine the relationship between antenatal syphilis and the educational level, then compare the prevalence of low birth weight between syphilis positive and syphilis negative. Problem statement. Despite the existence of effective preventive measures and effective and relatively inexpensive treatment options, pregnant women who are infected with the syphilis can transmit the infection to their fetus, causing congenital syphilis with serious adverse outcomes from the pregnancy up to 80% of the cases. An estimated 200,000 pregnancies are affected yearly, as 50% of these contributed to low birth weight. The previous study done in Webuye County Hospital, the prevalence of syphilis positive rate was 1.3%, while the adverse outcome, that is the low birth weight, was also a key pointer. Webuye County Hospital had reported high cases of low birth weights, as well as the increased positivity of antenatal syphilis, with an average of 1,600 new ANC visits, that's the first visit per year, of which the syphilis positive cases were noted to be high, 3.1%. Methodology. Study design. This was a prospective cohort study. A study area setting was Webuye County Hospital at the MCH. Study population, all pregnant mothers attending first ANC in Webuye County Hospital. That is March 2018 to September 2019. Sample size, 51 women with positive syphilis tests were matched with women with syphilis negative test and were followed up to delivery. So data collection methods used questionnaires, ANC booklets, and follow-ups through phone calling. Ethical consideration sought permission from Webuye County Hospital as well as the client consent. The results.
I'm Violet Akisa, as you've heard. Our results were put in tables and pie charts. Our baseline characteristics research according to our topic. We find that our mean gestational age was 22. Our mean age was 27. And some of our clients finished primary, some completed, and some completed secondary. Our pregnancy outcomes, we found that most of our clients had stillbirth, and our keynote was our low birth weight. We found that 15% of the cases had syphilis and 5% of the controls, which is 15% is a very high percentage. The pregnancy outcome, the stillbirths were 6% of the all live pregnancies, and of the negative, those ones were the controls, 4% of the live birth had stillbirth. Our birth outcomes, our stillbirths were 6 of the positives and negatives were 4. Our low birth weight, that is from our table, 15% of the positives and 5% of the negative. That is it. What is our discussion? According to our results, women with syphilis positive antenatally had a high prevalence of low birth weight despite the adequate treatment. This goes in hand with Watson Johnson of Tanzania, which states that the positive syphilis at delivery had been associated with low birth weights. This suggests that the current implementation of screening of treatment of syphilis and routine antenatal enrollment is insufficient to mitigate and contribute to poor birth outcome. This can be attributed with the late presentation of ANC, according to our results. What are we concluding from this research? Syphilis in pregnancy is associated with low birth weight. Apart from other infections that can contribute to low birth weight, but according to the results that we've got, we can conclude that low birth weight is associated with syphilis. Majority of the clients, according to our tables, shows that the first ANC, most of our clients came in the second trimester. Our mean gestational age was 22. Only 9.8% of the clients appeared in the first trimester, which means in case of infection, these clients might have got even the infections early. Syphilis can cross the Treponema pallidum bacteria can even cross the placenta as early as 9 weeks. If these clients started the ANC at 22 weeks, you find that at that rate, the rate of infection, the rate of the infant being infected from an infected mother is very, very high. And being that most of our clients started in the second trimester, they missed the critical time for essential interventions. The outcome of interest of this was the low birth weight. And we find that from our data, 15% of the cases had contributed to low birth weight. That is a very, very high percentage. What are we recommending? Strategies to ensure early ANC attendance should be enhanced to ensure early diagnosis and timely treatment. We've tried this, but we are recommending us to continue doing it. Screening of all women for syphilis during ANC visit in all settings, be it a low or a high prevalence area. And we also recommend that preconceptional testing to be done. Preconceptional testing to be done to this. We as midwives, we learned that it is good to enhance the preconceptional testing to these mothers. Before they conceive, it is good to make a test of the syphilis. And we also see that there exist unique opportunities to mobilize action to prevent the subsequent eliminate congenital syphilis. Those are our references. And we would like to thank the Webuye, the medical superintendent Webuye County Hospital, who really allowed us to do this research in the hospital. The nursing officer in charge who really gave us support, the MCH nurses and the maternity nurses who accorded us a good support in the follow-up of these class, ensuring that we get them on time. And above all, we also want to thank you all for sitting here and listening to us. Thank you.
Thank you, Violet and Madam Esther, for that great presentation. One announcement. We're still registering, guys, for the dinner. Kindly, if you've not done so, we are paying through the pay bill number. And then you will just confirm your payment at the registration desk. Kindly. So thank you for that. Our next presenter is Elizabeth. And Elizabeth Washuka. Oh, sorry, Eliza Washuka. I'm sorry. Eliza Washuka. As she sets up, I would like us all to just stand up. Sababu naona kuna vile mnanigawia plot na niko na mingi Kajiado. Kindly, can we just rise to our feet? Violet, you'll allow me to use your title. She's a GBV coordinator. So nowadays, maongeo mengi ko around GBV. And when you're talking to our children, there's this song we sang in Sunday school, yes. Head, shoulder, that was Sunday school. Head, shoulder, knees and toes. Oh, ilikuwa nursery kam. Wale walisomea nursery ya kanisa. Ilikuwa kam Sunday school. So we sang head, shoulder, knees and toes, knees and toes, knees and toes. And then what do we tell our kids nowadays? Mnajua the latest version. Wachanini na yenyu. And these are my private parts. Sindio? Hamjui your part? Oh, ni mnataka kuiona? My private parts. So, naona Eliza anataka kunisaidia hapa. So we are going to do head, shoulder, knees and toes, and then tukifika hapo mwisho tunasema these are my private parts. Si tunajua private parts? Sauti yangu siko mzuri nyororo. Naweza toa nyoka pangoni. Aya, twende kazi. Head, shoulder. And these are my private parts. Kwani hamna jua wengine hawajashika? Thank you. We can take our seats. So Eliza Washuka, ni sawa, tutarevise your part ya private parts. Eliza Washuka is an RH specialist, experienced in government and non-governmental public health. She is currently she has worked with USAID to Jenge Jamii. She previously was with FHI 360 and the Ministry of Health. She's affiliated to Gold Star Kenya. She's a PhD holder in population, and currently she's undertaking RH. She has MSN in reproductive health. She's a BSN graduate from KEMU, a diploma in KCRH, and she's done the comprehensive RH certificate. So we get to listen to Eliza. Karibu.
Thank you so much. As you've heard, my name is Washuka Eliza. I work for Gold Star Kenya, a consortium in USAID to Jenge Jamii. So, So I said I work for Gold Star Kenya at the USAID to Jenge Jamii. We have 3 partners in the consortium. We have Gold Star Kenya, we have Deloitte, and we have FHI 360. So in the consortium, We have 5 years funding from USAID, and we have five sub-purposes. The fourth sub-purpose is about increasing demand in reproductive health and increasing of healthcare seeking behavior, as well as quality service delivery. My subject of discussion today is about the emerging issues on the sexual reproductive health, specifically the role of peer-to-peer support in reduction of unmet family planning needs among adolescent girls, that's age 10 to 19 in Nakuru County. So, before I start, we've been having this issue of teenage pregnancy, which is a thorn in everyone's thinking, and we have quite a number of barriers. One of them is religion. We are so much religious, even to think about pregnancy in a teenager. And that's why you find in churches all over, these girls, we see them, we brand them, they are promiscuous. That's number one. The other thing is that we don't want our girls who are holier from we Christians to associate with those who have had pregnancy experiences. You tell them, don't move with so-and-so, she will teach you how to get pregnant. Is it so? We tell them, don't move with so-and-so, she'll show you how to get family planning, contraception. And the third thing is about policy. Everyone is quoting policy, policy, policy. But to go to the family planning guideline, the 2018 version, there's a clause there about consent, where they say consent is not a requirement in provision of family planning to youth and adolescents. I don't know whether it has been revised, but there is that protection in that context. So I go to my presentation. That's my outline. I've talked about the affiliation I work with, and statistically in Kenya, the CPR is around 40.2% among these adolescent girls, this age bracket, 15 to 19. And globally, Kenya, we have the highest teen pregnancy at number 3, where 1 in every 5 adolescent girls is already a mother or pregnant. Is it alarming? Very alarming. So the background continues. In the FP commitment of the 2030 targets is to increase the CPR in these adolescent women from 40 to 50% by the year 2020 and to 55% by the year 2025, and further reduce teenage pregnancy from 18% to 12% by 2020 and the same by 10% by the time we are at 2015. So the influence of social network approval and engagement with the wider community through mass and peer campaigns has shown to improve the uptake of FP and reduction of this teen pregnancy. So we tend, this peer influence tend to work well in these marginalized groups which adolescents fall in. Nakuru County has been earmarked as one of the counties with highest teen pregnancy, and we are at around 18.3% if compared to the national percentage of 18%, but we have those pockets in Nakuru County where we're extremely doing very bad. Example is Njoro, Cresoi North, Subukia sub-counties, where we have as high as 36%, 27% and 22% respectively. This is report from KHIS for the year 2021. So how do we do this? We did this intervention at a strategy we call the Binti Shujaa strategy, where we did the retrospective desk review of contraceptive uptake and ANC uptake for this age group within the year 2021. So the project, in partnership with Nakuru County Health Team, we implemented this peer-to-peer support group we are calling the Binti Shujaa. So these young girls, thank you. The young girls aged below 24 years with recent pregnancy experience and with babies less than 24 months were recruited in this. So 10 to 19 is the group that we recruited, but the champions who were to mentor them were below 24 years. So these girls, the Shujaas are the peers who have gone through pregnancy experience or have these babies and they have gone through it. So they mentor the 10 to 19 For one, those who are sexually active on how to take contraception safely, and those who are already pregnant, they are helped to go through pregnancy, early attendance, safe delivery, immunization, postnatal and family planning postnatally. So you can see the photos of these girls. They are quite young even by look, and these are girls who have babies already for them to qualify in the group. So the same girls are there. So these are the shujas, the mentors. They do have monthly meetings to discuss the progress. So this is one of their meetings. Results. In the year 2021, the proportion of the teen pregnancy was high, while the teen pregnancy was low, while the contraception was high. Sorry, it's an inverse. So after the intervention, within 12 months, this is what happened. You can see the graph that the pregnancies started going down. The girls who are coming pregnant reported lower numbers, and contraception uptake got up in the same age group. In conclusion, peer-to-peer support among teenagers play a great role in reducing the unmet FP need, and to avert these teenage pregnancies, stakeholders, including the teens themselves, need to be in the front line in this, and this enhances confidence and empowerment of the teen girls to prevent unintended pregnancy, because they are their peers who have gone through it successively, who are taking them through the same process. And with that, I would like to acknowledge the contributors to this, the USAID team, MOH partners, including Nakuru County Department of Health, and the implementing partners. And thank you.
Thank you, Eliza. I think we can give her a better clap than that. Thank you for that presentation. Issues around contraception and teenagers still remains an emotive gray area, but I know as we continue discussions and deliberations, we'll come up with a way forward. I'll call upon our next presenter, Justus Carter. Justus Carter. Justus Carter is a Tichen midwife with more than 4 years experience in midwifery, clinical instructor at Kijabe Hospital, worked with G&K for 2 years. And currently working with KUTRH Hospital. So Justus Karibu, Justus will be taking us through management of obstetric perineal laceration, a case presentation.
Good evening. Thank you very much for having me around here. Thank you, midwives, for attending this conference. I'll be taking you through this case presentation as my experience as a midwife in management of obstetric perineal lacerations. I know some people call them tears, but they are the same. Lacerations are common after vaginal birth. Trauma can occur in the cervix, vagina, vulva, including the labial, periclitorial and urethral regions, and the perineum. Most of these lacerations do not result in advanced functional outcome. Severe perineal lacerations extending into or through the anal sphincter complex, although less frequently, are more commonly associated with increased risk of pelvic floor injury, fecal and urinary incontinence, pain and sexual dysfunction with symptoms that may persist or be present many years after giving birth. The purpose of this document is to provide evidence-based guidelines for prevention, identification, and repair, stroke management of obstetric lacerations and episiotomy. Studies have shown that when midwives do not support the perineum in second stage, these mothers end up with bad tears than when the perineum is supported. WHO guidelines 2017 in obstetric care discourages liberal episiotomies in primigravida because they end up in third and fourth degree tears. Use of oxytocin in second stage of labor has also been said to contribute in perineal tears and therefore has been discouraged. I know most of the midwives, when a mother is in second stage, we say, instead of taking a lot of time, let's give oxytocin at that time. You have not started augmentation earlier, but you want to do it just in the second stage because you feel the mother is delaying, just for your own convenience. This is just for the purposes of midwives to know the muscles which are interrupted when we have these tears. The anal sphincter muscles, which we have the external anal sphincter muscles. These are thick circular which surround the anus, and we have the internal anal sphincter muscles as well. It's the role of the midwives to know these muscles, because when we are doing the repair, you need to know which muscles have been interrupted. There are classifications of tears. We have the first degree tear, which may not necessarily need to be repaired. We have the second degree tear, which should be repaired in the ward. And we have third and fourth degree tears, which we need to repair them in theater. The third degree tear, we have 3A, B, and C. And for 3A, we have less than 50% of the external anal sphincter being interrupted. 3B, we have more than 50% of the external anal sphincter muscles being interrupted. And 3C, both the external and internal muscles are interrupted. The fourth degree tear, we know the rectal mucosa which has been interrupted. This is just a pictorial to show the second degree tear. The fourth degree tear, you'll find that the mucosa has been interrupted. That is the anal mucosa. The identification of the perineal injury, assess the extent of bleeding, because remember these tears can also cause PPH. So you need to assess extent of bleeding, extent of injury, ensure urine bleeding, uterine bleeding controlled. This includes visual inspection and palpation. You may need to give antibiotics in third and fourth degree tears, but in first degree tears you may not need to give those antibiotics. That's just a choice of suture which I may not labor so much in. Tips and tricks. Line up key anatomical landmarks. That is hymen or ring, chameleon border. Angle your suture into the direction the retracted muscle is traveling to ensure a good deep bite. Deeper muscular sutures should be approximately skin edges to skin suture as with minimal tension. If any arterial bleeding vessel identified, secure it with a separate figure of each suture. We have complications which I may not labor so much in. This is how to do an end-to-end repair of external anal sphincter muscles. These are just the tips. I know the leadership which was organizing this conference will be able to send this to the midwives. In conclusion, when possible, let's all midwives avoid administering episiotomies. Just giving an example of your hem of a cloth. When that hem is not interrupted, it's very hard when you stretch it to tear. But when you put just an incision and try to pull it, it will tear, isn't it? So that's why we encourage the midwives to avoid administering liberal episiotomies. avoid oxytocin in second stage of labor, and support the perineum with a pad or a gauze. I know there's a training, I got some information from some midwives that there's no need of supporting the perineum, they just support with their bare hands. Your bare hands can slip off and you get a tear. So that's my conclusion. And I want to thank, I know my minutes are over. I want to thank the Kutra administration. KUTRIH is Kenya University, Kenyatta University Teaching and Referral Hospital, which is the newest hospital in town. I know a lot is happening there, and I want to thank them. I want to thank my lecturer, Jebet, who has been here. I want also to say thank you for all midwives who have attended here. That was just my share, and I know you have learned something.
Thank you, Justus. Justus Kata ametuambia tunapeana episiotomy. But what has made everyone mama is tuna support na mkono. I don't want any reactions, just as ako within. Hiyo tutamuuliza individually, si ndio? Just what is it called? Digest that info. So at this point, we are done with the first batch of presentation. I would like us to appreciate ourselves. And by the just as, we wish to appreciate all midwives for supporting perineums. Simnaji appreciate? Yes, so all midwives are to be appreciated for supporting perineums. Sasa, okay, we have, I am co-moderating with my partner, Ruth Muya. I will welcome her to take us through the remaining session. Karibu, Ruth.
Thank you, Anne. Good afternoon, everyone. My name is Ruth Muya, and I am Chair, MAC, Nairobi County, coordinating this session with my colleague again, Chair Mark Kanjado. The next presenter is none other than Charity Ndunge Mulei. And Charity, come over. Ndunge Mulei has a Bachelor of Science in Nursing from the University of Nairobi. She has a certificate in COVID-19 training, and she has Leadership and Management certificate from AMREF Africa. Karibu, Charity. She's a nurse trainer at Thika School of Medical and Health Sciences, a co-founder and managing director of Markles Deco. Expertise in teaching, training, and community health. Karibu. Thank you.
Mule. I think it's so easy to keep coming here until you have to actually say something. So, made on the client and their outcomes. So a number of guidelines have been made available to assist with nursing documentation, yet midwives still experience challenges in maintaining accurate and legally acceptable documents. I think this usually comes up sometimes or most of the times during our maternal mortality meetings. And the documents are found to be incomplete and not legally acceptable. And the blame most of the times may end up falling on the midwife. You may have done an intervention, but the fact that it was not documented, there's no evidence that you actually intervened. My study justification: complications arising from pregnancy and childbirth, as everyone is mentioning, the leading causes of maternal mortality in developing countries. And documentation in labor is very vital, since it shows care given to two lives that sometimes may be in competing interests. And it helps definitely midwives and other healthcare providers in taking appropriate and timely decisions on the progress of labor. My objectives were to determine the factors affecting the quality of documentation in labor among midwives at Kenyatta National Hospital Labor Ward, looking at their knowledge and then the staff-related factors, workload-related factors, and institution-related factors affecting their documentation. Methodology, it was a descriptive cross-sectional study among 51 consenting midwives selected using a simple random sampling technique at KNH Labor Ward. I employed a self-administered questionnaire for data collection, and I analyzed the data using SPSS. So the results, majority of the participants were female, majority married, and majority had a diploma level of training with none in certificate, 17.6% with higher diploma, 19% with undergraduate degree, and 3.9% with a postgraduate degree. On their knowledge, as you can see from the results, a majority know what midwifery documentation is about and the purpose of midwifery documentation, but they is, well, more or less a significant percentage that thought midwifery documentation is kind of a waste of time and is not a very important part of practice, but that is just a very small percentage, 3.9 and 5.9. On knowledge on the recommendable documents for labor progress, 100% agreed that the pathograph is an important document for monitoring labor progress, the CADEX, and only 25.5% thought the observation charts and the fluid charts are actually important. These are just a sample of some of the documents that we use throughout monitoring the progress of labor. Knowledge on important aspects to be documented during midwifery documentation. They displayed excellent knowledge on the important aspects to be documented. On their practice, you'll notice from the pie chart that, well, just slightly above average, 51% of the midwives document care that is given immediately after the care is given, with 23% documenting within 2 hours that care has been given, 10% documenting only after delivery. So they monitor the mother and they come to summarize or document everything after care, after delivery has already happened. And 16% they document only when it is convenient or only when it is needed. And sometimes when they are needed to probably now transfer the mother to the postnatal for postnatal care, so that is when they summarize everything and then hand over the mother. On the practice still, just highlighting some of the practices that I found eye-catching. 21.6% of the midwives would make entries ahead of time. That is especially in normal labor, whereby you can almost predict what the outcome of the delivery or the labor will be. So you summarize your entries, and then documenting for colleagues, 17.6%, where someone takes care of the mother, delivers, and then you document on their behalf. And then documenting only normal labor, 13.7%. On factors affecting quality midwifery documentation, I'll summarize them in my discussion and conclusions. So according to this study, midwives at KNH Labor Ward displayed high knowledge level on the aspects of quality midwifery documentation, but only an average of 60% practiced it as it is expected. So they have a good attitude towards midwifery documentation, and they have embraced teamwork and collaboration. And the study revealed that lack of sufficient time due to too many clients to attend to with few staff on duty, the nurse-patient ratio is wanting, and we can agree it cuts across. The nurse-patient ratio is wanting, hence midwives are unable to adequately document labor progress. And then majority of them are actually satisfied with the role of the hospital management in facilitating quality midwifery documentation. My conclusions: midwives at KNH Hospital have good knowledge of documentation, what should be documented, and the importance. Their practice of midwifery documentation is slightly above average, as we have seen, and several factors affect their quality of documentation. That is lack of sufficient time, too many clients to attend to, few staff on a shift, and work overload. My recommendations: there is need to employ more staff to increase the number of midwives in a shift. There is need to conduct frequent trainings on midwifery documentation just to remind and improve the documentation skills of the midwives. There is need to consolidate some documents to avoid too many documents for monitoring labor. And in this, you find that there is duplication of what needs to be documented. So midwives sometimes may find themselves documenting in maybe the pathograph and the cardex, and then they leave the rest of the documents because they feel it is a repeat of information. Then there's need to shift from paper to digital midwifery documentation. Then staff motivation through terms of employment and remuneration. Those are my references. Thank you.
A very good presentation. Do you agree with us? Very good. Thank you for that presentation. Very good documentation in KNH, the heart of the training center for nurses. Retro. Filling of the pathograph. Very good. Above average. We want to invite the next presenter, and that is Alice.